There have been a great deal of studies also looking at the angle anatomy, and we do know that the level of IOP lowering after cataract surgery is proportional to the resultant widening of the angle. And that might seem to differ with what I just said about wide open angles having a decrease in intraocular pressure. And that, I think, reveals what work we have left. We need to tease out the differences between narrow angles decreasing in pressure after cataract surgery versus wide open angles that also decrease in pressure. It's probably a factor on both sides, that it's multifactorial, and we're just trying to tease out the differences. We do know that lens vault may be predictive of IOP lowering. And there are things that are being studied right now through gonioscopy and anterior segment OCT, like angle morphology, characteristics of the iris, how thick the iris might be in the periphery versus centrally, and the lens vault. There are a lot more studies that are ongoing to tease out the exact differences in lens vault in patients who might decrease IOP versus those who don't. We know that doing cataract surgery alone in patients with chronic angle closure who have significant anterior synechia is not as effective, and that's also something that we'll talk about a little bit later in this session. One pearl, just because we're talking about cataract surgery and glaucoma, if you do have a patient who requires an LPI, and you know that this patient will be going for cataract surgery, which is the overwhelming majority of these patients, try and put the hole in the iris right beneath where you plan putting your incision for cataract surgery. And the reason for that is you'll have less likelihood of the iris coming into the wound at the time of cataract surgery if there's an LPI right beneath that cataract incision. So the science of IOP lowering, you can tell is pretty complex and still being studied. ECM remodeling and change in angle configuration are both relevant to the mechanism of IOP lowering. And studies are underway with advanced imaging as well as protein sampling of the fluid to better understand the process. What about acute angle closure? This is also a topic that we're hearing a lot about in the glaucoma circles, and it also has a similar conclusion that phaco is a great option. Dr. Lamb studied this in 31 eyes with acute angle closure and cataract surgery and found that phaco had lower IOP, less medication, and better visual acuity compared to the standard of doing a laser peripheral iridotomy. And you can see here from the table the comparison of the present study. This is the Lamb study with 31 eyes, showing that the prevalence of IOP rise at different follow-up time points is very favorable for the cataract surgery versus medications and LPI. This was further examined in the EAGLE trial, and we're just now starting to understand some of the results from the EAGLE trial. And in full disclosure, this is something that I'm still digging into, trying to figure out a little bit more about the nuances of the study. The study itself looked at the best approach to treating primary angle closure glaucoma with either standard of care, which is medication and LPI, versus lens extraction. Age of the patient was 50 or over, pressure 30 or higher, 419 patients. So this was a robust study, 208 assigned to clear lens extraction or lens extraction, and 211 to standard of care. Pressure was 1.18 millimeters lower in the lens extraction versus the standard of care. The conclusion here is that lens extraction showed greater efficacy, marginal if you look at the exact number, but was more cost effective than doing standard of care and should be considered as first-line therapy. This is something, again, that we're still trying to tease out the details, but it's very encouraging to see that cataract surgery alone could be quite effective and also cost effective. Chronic angle closure, a little bit of a different story here when it comes to chronic angle closure. A study in 2008 looked at medically controlled chronic angle closure glaucoma and found no difference in IOP after 3 months when you're comparing phaco to phacotrabeculectomy. Phaco-trab was on less medications but had more complications, as you might imagine. In 2009, the same group looked at medically uncontrolled chronic angle closure glaucoma. Phaco alone lowered IOP by 8 millimeters of mercury. Now, on the other hand here, phaco-trab lowered pressure 13.6 versus 15.9 when you combined with trab. Mean of 1.25 less drops, but it had more complications and more progression of the optic neuropathy. So there are a lot of inconsistencies here in the study, and we're still trying to figure out the best way to treat chronic angle closure